This week on the BackTable podcast.
Physicians, surgeons, and people that take care of other people, that keeping in mind that perhaps the correct saying, the correct model to go by is not practice makes perfect. It's perfect practice makes perfect. You got to identify your deficiencies, you got to correct them, and then practice again by fixing those deficiencies. So watching the videos, watching experts, coming in for observerships, doing all of that is going to help you identify your deficiencies. Watch your own videos and compare and contrast and see what you're doing so that you can improve next time. So continue practicing it, but fix it and make it the perfect practice.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got with me once again, Dr. Amy Park. Amy, how's it going?
Good. How are you, Mark?
I'm good. Another good day at the office. We've got another great guest with us today. Somebody I'm really excited to get to chat with, as much as we've been fortunate to have a lot of our friends on the show. Dr. Jamal Mourad is someone I'm excited to get to know better today. And welcome to the show, Jamal.
Thank you, Mark. Thank you, Amy, for the invitation.
We're excited to have you. Dr. Mourad is an associate professor of OBGYN at Mayo Clinic in the APD, the Associate Program Director for the FMIGS Fellowship down there. And we typically like to have our guests sort of introduce themselves, talk about your practice and sort of how you got to be where you are.
Great. Well, my story starts all the way back in Brazil. I was born and raised in Brazil. I came to the United States right after high school to pursue my undergraduate studies in Rochester, New York. So from the tropical jungles of Brazil to the frozen tundra of Rochester, New York, and then ended up in New York City for medical school, and then ended up in Arizona for training. This was back in 1995, and I have been here ever since. Landed at the Mayo Clinic recently after a long stint with Banner and the University of Arizona.
Oh, that's great. I know they're excited to have you at Mayo. And so we had you on today to talk about robotic surgery, but specifically robotic surgery in and around pregnancy. And so I know we've had a lot of folks on here talk about straight stick and laparoscopic surgery, robotics, different approaches, but what's been your experience with the robot in general?
I started my career with conventional laparoscopy, did that exclusively for about 10 years. And then Dr. Magrina, my mentor and dear friend, has always pushed me to, try different things and go the extra mile. So I started dabbling with robots in 2005, 2006, got about almost 3,000 cases under my belt now with a multi-port platform, and starting my journey with a single port now. And I have used the robot primarily for, or initially at least, for more complex cases when I wanted to push the envelope and do things that I thought I may not be able to avoid the laparotomy. And I now use it primarily, to do most of my procedures, from myomectomies to excision of endometriosis, uterine niche, and on pregnant patients on a multitude of different procedures as well. So I like the technology. I like the ability that it gives me to perform a procedure in a reproducible, efficient manner every single time, regardless of the bedside assist that I have with me, whether it's a learner or an assistant, a surgical assistant. I can always count on that reproducibility because I have control of most of my surgical field.
You mentioned single port. What percentage of your cases are done through the single port? And is that a big part of your practice? Is that something you're using just for specific cases?
Yeah, I just started recently. Johnny E., my partner here at the Mayo Clinic, is a big believer in the single port platform. And I see the benefit in situations where I can actually double dip and use the larger incision at the umbilicus to extract the tissue that I planned out to from the beginning, because there's a large fibroid or a large uterus or something that we're going to need to extend that umbilical incision. So instead of a multi-port approach, I just use a single incision to perform the hysterectomy or the myomectomy and extract the tissue in the same way.
Because we had Maggie Mueller and Kim Kenton on, and they're doing it almost exclusively for their urogynecologic procedures. But, one of the things they had mentioned was, for bigger pathology, kind of the stuff that I end up doing a lot, they felt like maybe it would not be as good an option. But it sounds like you're telling us, does it limit you in any way?
So it's a little bit more restricted in the sense that your range of motion is a little bit limited, but you have to switch somewhere in your brain that instead of moving your hands and your arms as we typically do with a multi-port platform, that we have to limit ourselves. We recently did 1,000-gram uterus through the platform. The hysterectomy was, as usual, the easiest part of the procedure. Within 30 minutes, you complete the procedure, and then you have to morse for about 45 minutes to an hour. So I thought that the single port did not restrict me in any way, whether for the hysterectomy or the cuff closure. And then we utilized the larger incision, the 3 centimeter incision. We extended it to 3.5, and we're able to extract it in a pretty efficient way. So it didn't limit me. I think it provided me with the same capabilities that I have with a multi-port, and it allowed the patient to have one less incision, the same size incision in the umbilicus as we would for a multi-port for contained tissue extraction.
That's great. So, pregnancy, let's talk about a little bit what type of cases you're performing on pregnant patients and what makes the robot specifically valuable, because we're going to have another guest come on at some point and talk about laparoscopy and pregnancy and different things, and just trying to think about the difference between the two, because we've got a lot of interesting ways to approach these cases. But what's your thought process and the benefits in this particular sort of clinical field?
Yeah, I really think of the robot as an extension of my laparoscopic skills. So I'm not trying to substitute conventional laparoscopy. I'm just making my experience more comfortable, more precise, more reproducible. I think of any complex procedure or most of my complex GYN procedures as good candidates for robotic assisted technology. It sort of augments what I do, and it extends my longevity in my profession, so I don't have many of the somatic dysfunctions that a lot of my colleagues that do straight stick laparoscopy have. For pregnant patients specifically, I think I have a preference specifically for example, high acuity situations when I have a cesarean scar ectopic, or perhaps a pregnant patient that requires a transabdominal cerclage because the movements are very controlled, very precise. The person that's bedside assisting me may be an early learner that doesn't have the nuances or the skills that are required to allow me to perform the procedure that requires fine dissection, and patient that has perhaps an enlarged uterus, and I cannot manipulate that uterus in any way, shape, or form. So it's like a symphony. It's like everything has to be in synchrony to allow the procedure to go well, safely, and efficiently, so that we can reproduce it every single time. So I typically do for pregnant patients, for example, I have done multiple, perhaps a couple hundred now, transabdominal cerclages, cesarean scar ectopics with live pregnancies, placenta accreta spectrum patients with incretas and percretas, and a multitude of other things like ovarian cysts, torsions, and things like that.
I don't really do these cases anymore, but can you just talk to us about your port access? Obviously, it's different. It's a gravid uterus or versus not. Obviously, it's different if you're using the single port, but also the anesthesia concerns. And then how are you counseling the patients about undergoing surgery? I mean, because they're worried about anesthesia as well, right?
Absolutely. It's always a point of discussion with the patients, with the families. And at first here at the Mayo Clinic, since they don't do any obstetrical care, I had to go through some layers to be able to get my cases approved here. And the first point of discussion was anesthesia for the pregnant patient and the possible implications, specifically in the first trimester. So we know that laparoscopy, robotics, open surgery all require general anesthesia in these patients. And we know that teratogenicity related to whatever medications we're using, whether it's a muscle relaxant or pain medications, is really not a concern, specifically after 11 weeks. The data is a little bit limited. There have been some reports, but I think when the benefit outweighs the risk, when push comes to shove, we got to do what we got to do. But specifically for elective procedures, where we're looking out for the baby's health and the mom's health, such as in transabdominal cerclages or ovarian cysts that have a viable intrauterine pregnancy, we try to get them in early second trimester. So 12, 13 weeks if the patient is symptomatic in the case of an ovarian cyst or a torsion, or for a transabdominal cerclage before the uterus gets too big and becomes an impediment. So there's no cutoff for the second trimester, but as the uterus enlarges, specifically for a transabdominal cerclage, it becomes pretty hard to maneuver your way around a 16, 17, 18-week size uterus without a uterine manipulator and to place a stitch around the isthmic portion. So I tried to get them in between 12 and 15 weeks approximately.
What percentage of your cerclages are done while they're pregnant versus not pregnant? So really the only ones I've ever seen were done. I don't know if you know who Arthur Haney was. He was my chair at University of Chicago, and he was like did thousands of these things, and he would do them through a 2-centimeter mini lap, the entire case, and it was like really showed me the value of a mini lap. And you're like, there's no way we're doing this case, and you realize, oh, wait a second, this is like an incredibly valuable incision. We would getting it out, and then he would place a stitch. We'd make a little bit bigger incision if they were pregnant, but he certainly sweat a little bit more during those cases. But are you doing mostly gravid, non-gravid uteruses for cerclages?
I wish I was doing them all non-gravid. That would be the ideal situation where the REIs and the OB would counsel their patients. We have situations where people actually have had 3, 4, 5 losses, and they tell them, oh, you should probably get a cerclage next time, and they wait until they're pregnant to actually bring them in. So fortunately, here in Phoenix, for the past probably, I would say since 2013, we've had a pretty good understanding with the local MFMs, and now the REIs are getting into it now. So the majority of patients are coming in a non-pregnant state, which is a super easy procedure to perform, specifically because you have a uterine manipulator in there. So it's very efficient, very easy, not stressful at all. But unfortunately, about 20%, maybe 25% of the patients will slip through the cracks and come in. Typically, the phone call that I get is on a Friday at 5 p.m. They say, well, we have a 13-week pregnant woman that has lost several babies and she needs a transabdominal cerclage. Then we have to go through all the hoops to get an OR and anesthesiologist that would be willing to do it within the next few days so that we can do it nice and safely. So I would say 20 to 25% of them are pregnant, and then the rest are pregestational.
What's your suture? Is it Merceline tape or?
Yeah, I've used the Merceline tape exclusively now. I tried Prolene for a while. Didn't like the way it really tightly cinches around the tissue. The Merceline tape has been a reliable friend for us. I do a needleless technique. I don't stick a needle through the cervical stroma at all. I just develop the planes just medial to the uterine arteries at the isthmic portion, and I slide the tape from anterior to posterior, cinch a knot real nice and tight, and move on. So
no needle at all.
No needle at all. I published that in 2014, and we haven't gone back.
Really? Because the blunt tip needle, that was Dr. Haney's other move, was he'd always grab the med students' hands and say it's blunt, and they would always flinch. I'm not sure you should be doing things like that anymore these days, but you could get away with that 20 years ago.
These evaluations are like, I didn't even realize some of the things you're supposed to be asking, like, what are your goals? What are you trying to get? And I was like, I looked at my evaluations and I was like, oh, I guess I should be asking these things. Like, I didn't even know until I had to access it for my, academic appointment. I'm like, oh, what is somebody going to tell me that I was supposed to review these things? I just go ahead and do the vag test. You know what I'm saying?
It's a very different world.
Different world completely. But yeah, the blunt needle was reassuring, but occasionally you get some, a little bit of bleeding with that. But are you doing single port or doing traditional laparoscopy, or rather traditional robotic surgery for your?
Robotics. Yeah, I've done multi-port exclusively for these. I think maybe I will venture out and do a non-pregnant or a pregestational cerclage with a single port, as it's pretty easy to do. So that will be my next adventure, probably trying the single port for these.
And are you sewing the Merceline tape with like the edges? I know you use like silk. Once you tie the knot, to tie the edges down to kind of keep the ends down. Do you secure it at all, or just tie a bunch of knots and leave it?
Yeah, I used to. I don't anymore. What I have changed over the years is that I tie the knot posteriorly now instead of anteriorly. That's a little bit different than what most people do. And I think at first I was motivated by the fact that the patients always complain of bladder discomfort, irritation, because that knot is pretty impactful. The Murslin tape is large and rough, and I imagine if you're pregnant and you have a 5, 6, 7 knots rubbing in your bladder the entire time, that may add to the discomfort. So we started doing it posteriorly for that reason. And also, it's much easier to remove afterwards. We've presented that at the AGL and the SGS a few years ago, but it's wish or a hope that one day I'm going to find a crazy MFM provider that's going to play with me on this one. I thought that if we perhaps tie the knot posteriorly and attach it to the posterior vaginal wall with a suture, retroperitonealize it, and then at around 36 weeks, with a spinal or an epidural, we could feel that knot, perform a small colpotomy, and then remove the cerclage since it's not through the cervical stroma because I don't use a needle. So you undermine the cerclage a little bit on both sides. You cut the knot and you slip it out, and then maybe perhaps allow for a trial of labor. Now, that's not a recommendation. That's not something that we have any literature on. This is just a crazy, wild dream that I have, and one day I will have an MFM friend partner up with me on that one.
Yeah, that's like, Amy's world is, getting into those spaces from below, being able to access those spaces. Or you should work with Dr. Zabakala and do a V-notes to get that suture out during the case.
There you go.
Yeah, they were doing the transvaginal removal of the kidney when I was a fellow here at the clinic. So it's not that. And then, lots of people have been doing colpotomy, ectopic management, all sorts of stuff in the past. I don't think it's that radical in our arc of the gynecologic history. You know what I mean?
Yeah. I mean, that's, I think, one of the big advantages of doing the transabdominal cerclage for patients that have had multiple losses and they're good candidates is that they can keep that cerclage for as many pregnancies as they, hope for. So there's no contraindication. The limiting factor is the number of C-sections that you're going to have. So I have had several patients over the past 10, 12 years that have had multiple successful pregnancies delivered at 36 weeks and beyond. So I think if I remove that vaginally at the time of delivery, they're going to have another cerclage for their next pregnancy. But if someone that's going to be in the one and done category, that might be something to consider, specifically if they have not had a C-section for a prior delivery. Typically, most of our cervical insufficiency patients deliver vaginally spontaneously unless there's some sort of odd history attached to it.
You just need like a cinch knot you can loosen and tighten and do that remotely somehow, like one of those
Endoloops.
Yeah, exactly.
Yeah. So we got to partner up with a good MFM, with a good urogynecologist, so that if something goes wrong with a colpotomy, and I imagine laboring with a fresh colpotomy suture might not be the best of ideas, but
I can't even imagine doing colpotomy on a pregnant lady. Like those tissues are like, I've seen some serious varicosities in those patients. But anyway, I just was curious because you mentioned all of these different surgeries and they're really heterogeneous. So you alluded to the cerclage and then, those kind of things. And that's sort of more, I guess, a pre-gestational and sort of second trimester thing. My understanding, though, of general anesthesia is that actually first trimester miscarriage is just common. And now we know it's more genetic. So I don't know if that association is actually like a real one or just like fears, you know what I'm saying, regarding miscarriage risk. But regarding the niche, I having done many video reviews for SGS and AGL and OGS, I've watched a lot of techniques for it. So you can use the bulldog clamps, you can do robotically, you can excise like literally half of the anterior wall of the uterus. Now we know that the C-section ectopics lead to placenta accreta spectrum. Tell us like what is your take and how your technique is? Have you done it? I've seen it, the section DNC from intrauterine approach. I've seen the from the top. I've seen the bladder go down. I've seen it not. I've seen, what are your thoughts on best practices?
Yeah, this is one of my favorite procedures as it relates to the minimally invasive approach. I get quite a few of these. I think I'm, one of the few crazy people here in town that will take all the placenta accreta spectrum patients to help them out in a minimally invasive way. So I look at primarily at the patient's wishes, of course. The residual myometrial thickness plays an important role in how I decide to approach the repair. So, for example, if the myometrial thickness is 3 millimeters or more and the patient does not want future fertility, I talk to her about the possibility of a hysteroscopic approach or a suction DNC kind of approach, as we're not concerned about future pregnancies. The bladder's far enough. I can do an ultrasound guidance during the procedure to make sure that whatever I'm doing from below is not affecting the bladder. Now, if the myometrial thickness is 2 millimeters or less, or if the patient desires future fertility and there's a significant niche, then I think the better approach would be laparoscopic or robotic in this situation. I use the terms interchangeably because I think of robotic technology as just an extension of laparoscopy, not as a separate procedure. But I think of the abdominal approach as a better choice for the patient because not only am I going to get complete resolution of the ectopic pregnancy and the retained products, but I'm also going to repair the lower uterine segment in a significant and robust way to increase that myometrial thickness, to prevent that from happening again, and to give them a better outcome for the next pregnancy.
That makes sense. There's so many techniques. Do you use the vasopressin to inject or the bulldog clamps as well?
Yeah, so for the pregnant ones, so if it's just a niche, I don't use the bulldogs, I just do the vasopressin. But we have had some live pregnancies like at 10, 11, 12 weeks where it doesn't sound like a lot, but my goodness, the vascularity to the uterus and the adnexa is so impressive. And of course, the products of conception, the placental tissue that's near the serosa is very vascular as well. So we start the procedure by doing a retroperineal dissection, either posterior or anterior, depending on how the uterus is positioned. Put the bulldog clips at the uterines on both sides, as well as the uterovarians to cut the blood flow to the uterus, inject the area with some vasopressin, and go after it. In all the cases that we've done, we've never had a transfusion. We've never had a bleeding event. It's almost, I hate to say it, but almost like a cadaveric dissection because you can really cut into that lower anterior uterine segment and get the repair done with a blood loss of less than 50 cc's almost all the time if you use these steps.
And you're closing it in 2 layers, assuming they want to get pregnant in the future?
Yeah, most of the time. I used to close with interrupted PDS sutures. Got away from that about 5-6 years ago. The barb suture now, deep layer first, second layer to imbricate on top. If I have any fluid leakage through that, I do a third layer to reinforce and increase the residual myometrial thickness. So typically two layers do the trick.
So are you using like methylene blue or something to inject it to see, or?
I usually do ICG, like a very dilute solution of ICG, not initially, just towards the mid portion of the procedure. I use a little Kroner manipulator so that I only put a little bit of ICG in the lower uterine segment to infuse the area that is defective so you don't get the whole uterus to turn green and the whole field to turn green. So that really helps me narrow down on the defect, resect the area that's involved without having to be guessing.
So when you are operating on patients who are pregnant, who want to stay pregnant, whether it's a cerclage or an ovarian torsion or some other reason why you are operating on folks who are pregnant, how a pregnancy would change your approach to using energy?
Yeah, this is one of the few things that we actually have data on, right? There's so much that we do that's not evidence-based, but the use of monopolar and bipolar energy is totally okay in the first, second, and third trimester. So, of course, judicious use all the time because like any other surgery, whether it's endo or torsion or a niche, we don't want to use energy if we don't need to. But judicious use, I always use short bursts, only when I need to, and keeping things hemostatic, it's super important. So whether it's a transabdominal cerclage or a ovarian torsion, I use the same approach. Use it when I need it, but I don't hesitate to use monopolar, bipolar, vessel sealers, whatever I have in hand, it's okay to use.
That's interesting. Now, patient positioning in pregnant patients?
Yeah, that's one of the important considerations also, depending on whether, you need vaginal access or not. With some more advanced gestational age transabdominal cerclage, because I really need to make sure that I can see, the vesicle cervical junction, that I can get to the isthmic portion. Since I cannot put any manipulators in, I typically have an assistant come in with a sponge stick to go to the anterior or posterior fornix. After I mobilize the bladder, after I get everything ready to go before I pass that cerclage, I have them put a sponge stick in there and just give me a little bit of a push, so I can determine the exact location where I want my transabdominal cerclage tape to go through. Outside of that, a supine position is okay. Low lithotomy is okay also. And then if the patient is 16 weeks or beyond, mid to late second trimester or beyond, then we always have a leftward tilt, a little bit of an angle to get the uterus off of the major vessels.
What, now you're not doing them that late for cerclages, are you? The 16, 18 weeks, or is that mostly for adnexal surgery?
Yeah, we've done up to 16 weeks. I've done a triplet pregnancy against my best judgment. We've done a triplet pregnancy that was just ginormous. My kids used to say huge when they were little, bigger than huge. But this is a really interesting patient that had 5 prior losses and then spontaneously conceived with triplets. And my fellow and I counseled her thoroughly that was not indicated in her situation, that we had not had any prior experiences, and that we recommend against placing it to cerclage. And I remember this day as if it were yesterday. This patient started crying, grabs me by the collar. She grabbed my white coat, and she said, "I am meant to be a mother. You need to do this." And oh my
Oh,
gosh, that was just like such an emotional visit. And we did it, and to my surprise, she delivered at 35 weeks and 2 days electively
wow.
with a cesarean section. So got invited to their birthday party, and we had a big celebration together. It was phenomenal. So yeah, I prefer not to do anything beyond 15 weeks, but if it's a special circumstance, we can consider it. Another thing that people can consider during a surgery, an elective procedure, or a surgical procedure on a pregnant patient, whether it's 20 weeks, 25, 28, 30 weeks, is airplaning the table to the left, specifically if the pathology is on the right, whether it's the appendix, the adnexa, the gallbladder. If you have the patient tilted and then you airplane the table, that will kind of shift the uterus to the left and expose the adnexa, the appendix. It makes it a little bit easier. You can go all the way up to like maybe 25, 30 degrees airplaning the table, and that helps quite a bit. If it's on the left side, it's a little bit more challenging.
That's pretty extreme airplaning. It's not.
Yeah, up to.
I guess T-Berg is probably the most useful assist you have in a pregnant patient in terms of uterine mobility, because you're not really grabbing it or pulling it. You're letting the weight of the uterus pull itself. It's like a big fibroid uterus. The more you can get a patient on their head, the more it's up and out of the pelvis without having to really pull it up and out of the pelvis.
Yeah, early on is super helpful, especially if your focus is in the lower uterine segment, like a cerclage. But for adnexal surgery, it becomes a little bit tough. The steep Trendelenburg will pull the adnexa really close to the upper abdomen and the camera, so it limits you a little bit that way. So kind of in between, we use for cerclages, we probably use close to 20 degrees for Trendelenburg. We probably go maybe 12 to 15 for adnexal surgery or something like that, to allow for a little bit of distance, not to get the uterus too close to the camera.
So what kind of adnexal surgeries do you see most? I mean, torsion seems like the one that would be the most common, but I've had some where patients have, pain. It's severe. You get in there and it's like an endometrioma or some other. It's not twist, it's fixed, and you're having to deal with that. That's a tougher one to do.
For sure. I think torsion is probably the primary diagnosis, is the most common diagnosis that takes women to the operating room during pregnancy: torsion, ovarian cyst, and things like that. It's really hard to make that diagnosis of torsion, especially if the uterus is really big. I mean, Doppler flows are helpful, but we all know that even if there is intermittent flow, the pain is there. The pain is impactful for the patient. So I go mostly by symptomatology and inability to resolve the symptomatology. So if I make a diagnosis of an ovarian torsion, we want to take that patient to the OR within 4 hours of making that diagnosis to try to save their ovary. But you're right. Sometimes you get in there and the ovary looks totally fine and not ischemic, not necrotic, but that's a good thing because we got to it before that happened, or perhaps there's intermittent blood flow to the adnexa that helps with that. But removing the cyst or doing an oophorectomy, depending on what the situation is relatively simple to do after 20 weeks, because when the uterus comes out of the pelvis, the adnexa is definitely approachable and reachable. So it becomes a little bit easier as opposed to maybe an early pregnancy where the ovaries are tucked behind the uterus in the cul-de-sac, and you really have a hard time reaching, especially with the small laparoscopic instruments. I use a pretty cool tool called a laparoscopic paddle. It looks like a pool skimmer, and I use it for all my cerclages, but occasionally I use it for adnexal surgery as well. So it goes through a 10 millimeter pore in the left upper quadrant, and we just slide it in. My assistant can open it up or close it depending on the size of the uterus and give me a lift so I can look down or look up with my 30-degree scope to give me better access.
And with ectopics nowadays, they're saying even if it's like pretty dead looking, leaving it in, that the likelihood is that the ovary will, at least in some way, some function of the ovary will remain, even if it looks pretty dead. And so I think I've gotten further and further away from taking ovaries out, especially in young reproductive age women. And cystectomies in those patients are really, really challenging. They're just the vasocongestion, the venous congestion is just everything you touch is just mush. And so just letting the ovary, untwisting it, letting the blood supply leak out of the ovary back into the patient and let the venous congestion kind of resolve on its own. And most of the time I find that that's enough. I mean, yes, they're at risk of torsion, but what's your feeling on pexing the ovaries?
I go back and forth. Again, not enough data there to suggest that one is better than the other. In patients that have had a hysterectomy and have torsion, which is pretty rare, but it's possible, I favor pexing the ovaries to prevent that from happening. Again, if we're preserving the ovary, I kind of pexy it to allow for decreased recurrence. In the patients that have a uterus in place, the anatomy looks pretty normal. I tend not to, and I don't know if that's the right or the wrong thing, but it's served me well so far. I have not had, a significant number of recurrences that I can recall that would make me change my mind on that. I agree with leaving the ovary instead of removing it, even if there are ischemic changes that are pretty apparent. If we detorse it, give it time, that you see the color changes happening. It may take 10, 15, 20 minutes, but if you get it in place, you treat it well, most of the time, I think we can save the ovary.
You mentioned Accreta, Accreta, the spectrum of disorders associated with that we see more commonly in patients that have had multiple C-sections. But you mentioned that you're now doing those robotically. Are you talking about hysterectomy?
So either hysterectomy or a revision of the lower uterine segment. So we've had patients that have had placenta accreta diagnosed early on, and some people find that hard to believe, but our imaging is so good nowadays that we're really truly capable with an ultrasound, a well-done ultrasound, and sometimes an MRI if there is any question, to identify patients that have this type of disorder. And for patients that are done with fertility, I definitely encourage them to proceed with a hysterectomy, and we can do that in a minimally invasive approach like you would do any other hysterectomy. Few modifications because you don't really want to put a manipulator right through placental tissue or get it through the lower uterine segment. So we take care of the blood supply before we put a manipulator in by putting clips on the uterine arteries. Or in the past, we used to actually send them to IR and get them embolized prior to the hysterectomy so we could put those manipulators and not worry about bleeding. But today we don't do that anymore. If the patient wants to preserve fertility, we treat them like a niche. It's a wider dissection. Sometimes it does involve the bladder, sometimes it doesn't. But we can simply mobilize the bladder flap away. If it's not a percreta, if it's just an increta, whether we're millimeters away from the bladder or not, you just mobilize the bladder, do a wide resection of the defect that contains the pathology, and then you reconstruct it the same way you would a uterine niche. So we've done multiple of those successfully. Patients have been able to conceive again, and it seems to be protective in one way or another because you're now reinforcing that layer and making it less likely to recur. Now, some patients have extremely thinned out lower uterine segments for one reason or another, and that becomes a little bit more difficult to reapproximate those edges, but it's doable.
Now, one of the things we found, because the first C-section scar pregnancy I ever saw very early was one that when I was starting my career, one of the MFMs said, "You go take care of this laparoscopically." And I was like, "Well, I've never seen one." He's like, "Yeah, we did one years ago with oncology. We did a big X-lap, and it was so little and stupid, and you could just do it laparoscopically." So call it around. But one of the things that I sort of had to think through was the manipulator. And I actually used the transabdominal ultrasound and turned the manipulator backwards so that it frowned instead of smiled, and kind of rode the back wall of the uterus and then flipped it around. And I've done that a bunch of times now, where just sort of, otherwise you can hook into the niche and you don't want to put it in there. So just putting it in upside down and sort of riding it, the posterior uterine wall in, and then flipping it around has been pretty successful. And you can watch it go in on transabdominal ultrasound during the case.
Yeah, that's great. The pathology is anterior, so if you can avoid that, from the very beginning, that's very helpful. I use a multitude of different manipulators. I have my favorite. I don't mark it for anybody, but I have one that has a light source attached to it, and it's partly reusable. Part of it is disposable, but it does have a metal tip component to it that's non-disposable and has a slight curve to it. So when I introduce it, I do it like you just described, Mark. We put it in, going in facing posterior as if the uterus was retroverted. And as the tip goes, beyond the internal os, then we can put it in the cavity and rotate it so it's in the, in the anterior configuration. So that's been very helpful also.
What lights up on the manipulator? Is it the ring?
So the colpotomy cup has a fenestration in it, and we attach a cystal light cord to the back of the manipulator, and it's amazing. I mean, it's just like when you have a multitude of early learners, to be able to ask them to, get me that light source to 3 o'clock, 6 o'clock, 9 o'clock, 12 o'clock, it's very impactful. And when you have disease that's a little bit more than what you expect, such as, larger uteri, it's such a sturdy manipulator that it really allows me to get to the deep posterior cul-de-sac with my 30-degree scope and unequivocally see that cervical-vaginal junction. It's very helpful.
Oh, which one is it? Who makes it?
It's called Forneci, F-O-R, Forneci, like as in C.
Oh, interesting. That's I've never heard of it, but that sounds really cool.
I've never seen it in real life. I've never used it. I mean, it sounds great, and there's definitely moments where I'm like, big dissection, big uterus, distorted by fibroids or prior C-sections or endo, and you're making your colpotomy, and you're like, I really want to see this colpotomy cup. I really want to see blue or green or whichever.
Oh, this is unequivocal.
Right. Because some of them, like in the V-Care, the cup, there's 2 cups, right? And you could imagine if you're too low, or you could imagine where are we exactly? And if you're not really, if there's a bunch of anterior pathology higher up, your green cup could be hidden. So no, I think this is one of those. It happens rare. Certainly happens much more rarely now than it did when I was starting out. But yeah, it'd be nice to just know, okay, this is where we're going.
And especially when you're in a situation where you have a multitude of different level learners. I'm in an environment where we have medical students, we have residents, we have fellows, we have international observers. So this type of, reproducibility with the manipulator is very valuable, because it's impossible not to know, because the light shines right through. So I turn the light intensity down to 30% because it's too much. Sometimes you need sunglasses, to be looking through the camera. Once you make the colpotomy, I turn the light off when I get to, 75% of the colpotomy, because I keep the light buried in the tissue because you can see right through it. Another advantage here, whether, you're dealing with a hysterectomy or a stage 4 endo, is that if you keep the light source at 30% and you have a viscous organ on top of it, let's say the bladder anteriorly, or the bowel is pulled up and stuck to the lower part of the cervix or the uterus, the light will not shine through. So I tell them, do not cut. Do not do anything until you see that light. So once you mobilize the bladder sufficiently and you mobilize the rectosigmoid sufficiently, the light will shine right through it. So you can resect your endo, you can do your colpotomy, you can do your niche, because most of the time with the niche pathology, you have the bladder pulled into the niche. And that's one of the most challenging parts of the procedure for some people, is to get the bladder mobilized safely. And this type of, unique manipulator helps quite a bit.
Can I just ask, because, gosh, when you just told us at the beginning of this episode about your experience, you're really one of the pioneers in robotic surgery. And how did you develop this skill set? I mean, if you trained in 1995 and you started up with a robot in 2005 and you're doing all these surgeries, no one ever trained you how to do these surgeries. Like, did you watch videos? Did you know what I mean? Like, now you have this kind of a big referral pattern in the greater Phoenix area because you pioneered a lot of these surgeries. You're known for it. Like, how did you push yourself to do these things?
It's like, I tell my kids all the time, you got to do what you love and you got to love what you do. And when you do those things, when you combine those things, you go out of your way to get better, to learn more, to do things that, are going to push the envelope. So when I first got interested in robotics, I was searching for the best of the best. And that was easy to find at that time. That was in 2005. Dr. Magrina by far was the most experienced and most eloquent surgeon in robotics. So I called him up and they said, "Hey, Dr. Magrina, can I come and shadow you here at the Mayo Clinic?" And that was that was in 2005 when I came in to observe Dr. Magrina. And Dr. Roseanne Coe was his fellow at the time. So I spent about 3 days, 4 days shadowing him, watching what he did. And, the fluency of the movements, the elegance of the movements just really fascinated me. And, he's not doing your 50-gram TLH. He was doing stage 4 endo cancer patients, pretty complex procedures at that time in a very efficient and reproducible way. So that prompted me to every conference that was available out there, every video that was published. I can recite, the surgical procedures that I watched because it was just simply gratifying and fascinating. So for the cerclages, for example, I had never done one before on a pregnant patient. And I partnered up with our maternal fetal medicine, Dr. William Kluhl, who was my mentor in residency. He called me in 2013. He said, "Jamal, you're doing all these things laparoscopically and robotically. Why don't you do our cerclages for us?" I said, "Simply because I've never seen one. I wouldn't know what to do." He goes, "Well, I've never done a laparoscopy, but I can come and sit with you and tell you what I would do." And that was my first laparoscopic robotic transabdominal cerclage in a pregnant patient on a morbidly obese patient at 14 weeks gestation with 3 prior C-sections with a sea of adhesions that I can't tell you. That was one of the most difficult procedures I've ever done. But I did that with the MFM sitting at my side telling me this is how I would do it abdominally. And I tried to reproduce that as much as possible. And I can tell you with a lot of pride that since that day in late 2013, I believe it was December 2013, in Phoenix, there have been no transabdominal cerclages that are done by a laparotomy anymore. So we transformed the landscape for this type of procedure here, that really was born out of a passion for doing minimally invasive surgery and a visionary on the maternal fetal medicine side of the equation that said the patients can benefit from this much more than they would otherwise. So watching videos, watching experts, we have a lot of international visitors that come in and they only get an observer badge. And some medical students and residents kind of frown upon the fact that they're not going to be having any hands-on experience. But I can tell you there's a lot to be learned by, observing the masters of surgery. Now, that's how I learned early on by watching these great, amazing mentors that we have through the AAGL and throughout the years. So impactful for sure.
No, it really is an incredible resource. I mean, I feel the same way about certain videos. There's cases I watch again and again and again and again and again. I mean, the early ones were sort of what got me interested in all this stuff. And the fact that in the earlier pioneers would have to sort of just imagine what to do. And now you can go and watch someone around the world do it and go, I think I know how to do this part. I know how to do that. This is the same. I think I know how to, this is the same entry plane here, right? I can get to my uterines here or whatever. And what's different about it? And if you've got someone who is willing to say, I know how to do it open, it's just, the technical parts you can do. And I've done that a bunch. I was doing laparoscopic surgery and a colorectal surgeon I used to operate with, couldn't tie knots laparoscopically. So he's okay, put a stitch there. I'm doing all the suturing and all the tying. It's their surgery. It's just as if they watched a resident sew it and observed it, right, in an open case. But because we have the technical skills they don't have, it allows us to really push the boundaries and do it safely and, in ways that are for the patient, not just because we can, but because We know how to do these skills, and suturing laparoscopically is not something a lot of surgeons know how to do, straight stick especially. But it's one of those things that allows us to push the envelope. But I'm always amazed by the pioneers. I think Amy was alluding to that. But to go, I'm just gonna try it. And again, the laparoscopic C-section scar topic was one of those. I was like, I guess I just have to do it because no one else is around, and they need it done. And this is, I feel, confident we can do it. But that's sometimes just that your hand is forced a little bit.
I got to tell you, we all have the skill set, right? All the urogyns and mixed people, we all have the skill set to do whatever it is, whether it's suturing, whether it's the tissue dissection. I have the strong belief that if you have good anatomical knowledge, you understand the pathology, and you have the skills, there's really not much that cannot be done in a minimally invasive way, right? And then if you take the handicaps out with the inefficiencies of certain, instruments and perhaps making sure that you have a consistent assistant, then that really can take you to the next level and allows you to do much more complex, high acuity cases. Everybody's afraid of the pregnant patient because of the risk of injury. And the data is very clear here. It's the best approach for the patients, regardless of trimester of pregnancy, first, second, and third. It's a laparoscopic approach, unless there's some sort of absolute contraindication, whether it's an appendectomy, a cholecystectomy, or gynecologic disorders. And you just have to respect the anatomy, the uterus as it grows out of the pelvis, placing your trocars appropriately, whether it's a Varus needle, direct entry, or a Hassan technique. You just have to be about 6 centimeters above the fundus. And then if you want to take a left upper quadrant Palmer's point approach every time, that's okay as well, but you don't have to. As long as you don't push things towards the pelvis, towards the uterus, it's okay to do a Varus needle. It's okay to do direct entry if you prefer. I don't like direct entry, but I do Varus and Palmer's point all the time, and Hassan when we need to.
That's something that I've just gone to. If they've had almost any prior surgery, I just go Palmer's point. Rarely I'll do right upper quadrant if they've had, gastric surgery and things like that. But I've gotten to it's just such a easy thing. And it's funny, I learned it in fellowship, and now I talk to folks in my fellowship who go up there and like, oh yeah, they never do that anymore. Like,
oh my goodness, yeah.
Or they have a different approach. Or they do again how these things shift. But I wanted to draw attention to something you said though, and you've named a couple of mentors or partners or colleagues. But I think that's a big part of becoming a better surgeon is humility, is relationships, is understanding what you know, understanding what you don't know, putting the patient first, and having the right people in the room at the time. Almost everything I've learned is because someone took the time to teach me, because someone took the time to make a video, someone took the time to come to my OR to help us take better care of patients. And I think that's been the most fun I have in the OR is when you get into a really tough case, but you look over and you see somebody who has a different skill set than you, and you feel safe doing things where before, if you were by yourself, it feels very unsafe. And there's nothing worse than being in a situation where you just go, man, I wish I wasn't here right now. This is just painful. And so when you've got good colleagues and you've got good partners, and that's outside of your department, so much of what we do that where we're uncomfortable is because we didn't train on bowel surgery. We didn't train on bladder surgery. We didn't train in MFM or, in pregnancy. A lot of us gave that up years ago. And so keeping those relationships and, really maintaining and nourishing those relationships, to me, is the most fun part of getting to do what I do. And, whether that's with trainees or learners, but also colleagues outside of the department, really is one of the, I think is the safest or the only safe way to really push the boundaries in a way that keeps us from really just being cowboys and doing things just to see if we can.
I agree. I think Dr. Falcone brought this up. Tommaso said he couldn't have innovated in this space without the colleagues. Like what you're talking about with your MFM colleague, that's how he was with, doing these laparoscopic birches with Mark Welters. And then also, I'm just so impressed with your drive and curiosity and your interest, because that's your passion for the minimally invasive surgery made you want to learn more and constantly improve. I mean, you're probably just analyzing all the time how to improve your technique. I mean, I know I do. You run into problems and you're like, how could I avoid that painful situation in the future?
I think it's rare for all of us that do this for a living, that really enjoy what we do. I can tell you that there is not one day after surgery that I go to bed and I don't think about okay, that went great, but what can I do next time to make it even better? So it's that constant search for how to make it, how to get close to perfection every single time. And watching videos is something that I still do to this day, whether it's my own videos when I, had some challenges that I, want to make sure that, we improve on that, or continuously going through Surgery U and other platforms to watch other experts do their thing, because you learn something new every single time. So I can't, for the early learners there, for the fellows, the residents, and even for, some of my own friends, old people like me, there's so much value in learning from other people's experiences and how they do things. I tell the fellows there's my way, there's a wrong way, but in a joking way, because there's a million ways to do the same thing. And that's the beauty of, our specialty, is that it's not just a cookie cutter kind of thing. We need to adapt. We need to do things that are not written in a textbook to be able to handle the tissue in a respectful way, to get to the pathology in a safe way, and more importantly, to be safe, efficient, and have a reproducible procedure that everybody can do.
I tell interns all the time, I mean, I know you're carrying a pager and you're dealing with ER stuff, but come to the OR. Like, 'cause a lot of them are intimidated. They're, well, it's not my case. It's an upper level case. I'm like, listen, you come to the OR every time you got a minute. Just come hang out. Just come watch. I've learned so much between cases. I'll just wander in other people's ORs, bariatric surgeons, general surgeons, colorectal surgeons. I like to do how they set it up, what their sort of like process is. I think you have to be curious about this. I think there's so many things we just think we know the answer, and you go, God, there's a better way. And being a good listener and realizing your students may have ideas, your residents may have ideas, and being able to be open and creating that safe culture, that psychologically safe culture in the OR where people can help you solve problems. Who wants to do it alone? Who wants to be the only one responsible? It's way more fun to get in trouble with your friends than it is to get in trouble by yourself.
I fully endorse that.
Yeah, absolutely. And the other thing I will say is, once you know the steps of the procedure, everything else is like a series of tips and tricks. You know what I mean? And recognizing the planes. And that comes from experience. So I'm always I sound like a broken record, but I'm always telling the trainees, I'm like, judgment comes from experience. Experience comes from making mistakes. I'd like to save you from making these mistakes. So I'm just telling you now, this is some things to avoid, because I learned the hard way. And people were like, okay, I don't want to learn the hard way.
No, I mean, I think we all have that experience where it's certainly more so earlier in my career, but where you see something go, okay, like I've been looking at this for like years. And I'm seeing this approach or this one move where the bladder just falls away, and you go, why was I fighting it this other way yeah. And you go, you had one case, and it took the 123rd case of doing these things where you find out that was so much easier. Why was I doing it the other way for so long? Or you watch a video and go, oh yeah, this is obviously better. I was struggling for this for so long, and it's the simple thing that and if you don't keep watching and looking for that answer, you're going to continue to struggle. And so for me, I always joke, my laziness has been one of my greatest gifts. It's like, how can I get home? How can I get sleep tonight and feel like this patient's not going to have a problem and call me later, right? Yeah, I want everything to be done so that I can sit down and not be bothered, right? It's like, my motivation is to be home, and for the patients to be home safe, and for all those things, the things to go well. So I'll spend minutes in the OR to save hours and days. That's something I see again and again and again. Look, we're positioning, all those things.
Yeah, that's one of the beauties of our specialty, right? If we do our job well during the day, there's very little that's going to happen at night. So, that's it sounds like laziness or selfishness, but it's not. It's the right thing to do for the patient, because
definitely for me, it's definitely selfishness and laziness. No. It's like, let's be very clear.
Yeah, and not rounding the next day is even more important. I tell all the fellows, our goal is not to have anybody in-house, because they're doing so well, they can go home the same day. So the less people we have to round in the morning, the better it is for everybody.
Well, no, it's funny when I'm a CMO now, and so I've got this whole hospital I have to, meet the nurses and go on all the different floors, and I'm like, I don't know where anything is. I don't know, I'd have like a patient here and there over the years, but it's this whole other world. Clinic, I got. OR, I got. Hospital, I'm sorry, who are you and what is your role here? And, it's just a whole other world. Oh my gosh. Hospital medicine, my goodness. But But yeah, it's, if I have to round on more than one patient, it's like, oh, devastating. And you forget, you still have to round on 15, 20 patients. But
Absolutely.
no, it's what's best for the patient for sure. But we've kept you long enough. It's an absolute pleasure. I look forward to seeing you in, this will air after AAGL, but I'd love to get a chance to sit down. And again, this is what this show is where we see the people we're fans of, people who are our mentors, or the people that we admire, that we try to grab at AGL and sit down and have a cup of coffee or catch up and learn what they're doing. But now we get to share those conversations with anyone who wants to listen to our podcast. So what you do is incredible, and the experience you have is so valuable, and your insight is so valuable to me, and I'm sure our others and our listeners as well. So thanks so much for making time, and appreciate your patience with our setup here today. But it was a pleasure to get to chat with you.
Oh, I really appreciate it. Thank you both, Amy and Mark, for inviting me. I'm a super big fan of BackTable OBGYN. I listen often on my way home. I drive about 40 minutes to get home every day, and that gives me a great opportunity to listen to all these incredible podcasts. And perhaps one last message to the listeners, to the early learners. I have 3 boys, and they're all into basketball. They all played high school. One is a college graduate now. The other one is just starting college. I think something that translates into our specialty, into our practice as, physicians, surgeons, and people that take care of other people, that keeping in mind that perhaps the correct saying, the correct model to go by is not practice makes perfect. It's perfect practice makes perfect. You got to identify your deficiencies. You got to correct them, and then practice again by fixing those deficiencies. So watching the videos, watching experts, coming in for observerships, doing all of that is going to help you identify your deficiencies. Watch your own videos and compare and contrast and see what you're doing so that you can improve next time. So continue practicing it, but fix it and make it the perfect practice.
Wonderful. Absolute pleasure. Thanks so much,
Thanks,
Jamal. Look
Jamal.
forward to seeing you soon.
Thank you, guys. I'll see you all in New Orleans.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
And Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and Digital Marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Overjinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.